Your cholesterol results came back completely normal. LDL, normal. HDL, normal. Triglycerides, normal. You feel relieved. Your doctor seems happy. You go home thinking your heart is fine. 6 months later, you have a heart attack. How is that even possible? This happens more than you think. And I see it in my clinical practice regularly. Patients who did everything right, took their medication, watched their diet, exercised, and still ended up in hospital with a heart attack. Today, I am going to explain exactly why this happens. And I am going to introduce you to 2 numbers that most doctors never check. But that could be more important than anything on your standard cholesterol report. This is MRCPdoc, internal medicine physician. Let's start from the very beginning. Why your cholesterol result might be misleading you. First, let me explain what cholesterol actually is. Cholesterol is a fatty substance your body needs. It is not poison. It is not evil. Your body actually makes cholesterol because it needs it, for building cell walls, making hormones, and producing vitamin D. The problem is not cholesterol itself. The problem is how it travels around your blood. Cholesterol cannot dissolve in blood, just like oil cannot mix with water. So your body packages it into tiny carriers called lipoproteins. Think of lipoproteins like delivery vans carrying cholesterol around your bloodstream. Some of these delivery vans are helpful. Some are dangerous. The dangerous ones, the ones that cause heart disease, are called LDL particles. They carry cholesterol to your artery walls where it can get stuck, build up, and eventually cause a blockage, a heart attack or stroke. Now here is the critical point. And this is what most standard cholesterol tests miss. Your standard LDL cholesterol test tells you how much cholesterol is being carried. But it does not tell you how many vans are doing the carrying. And this difference, the number of vans versus the amount of cargo, is everything. The van analogy that changes everything. Let me make this very simple with an example. Imagine 2 people. Let's call them Sarah and Ahmed. Sarah has 10 large delivery vans, each carrying 10 boxes of cholesterol. Total boxes, 100. Ahmed has 50 small delivery vans, each carrying 2 boxes of cholesterol. Total boxes, also 100. On a standard cholesterol test, Sarah and Ahmed look identical. Same LDL cholesterol level. Same result. But Ahmed has 50 vans on the road. Sarah only has 10. More vans on the road means more chances of a van crashing into your artery wall. More chances of cholesterol getting stuck. More chances of plaque building up. More chances of a heart attack. Ahmed's real cardiovascular risk is dramatically higher than Sarah's, even though their cholesterol numbers look exactly the same. This is the fundamental limitation of standard LDL cholesterol testing. And this is exactly why people with normal cholesterol have heart attacks. What is ApoB, and why does it matter? This is where ApoB comes in. ApoB, short for apolipoprotein B, is a protein that sits on the surface of every single dangerous lipoprotein particle in your blood. Every LDL particle has exactly 1 ApoB on its surface. 1 particle, 1 ApoB. No exceptions. This means that if you measure ApoB, you are directly counting the number of dangerous particles in your blood, not how much cholesterol they are carrying, how many particles there are. Going back to our analogy, ApoB counts the vans, not the boxes inside. For Ahmed, his ApoB would be very high, reflecting his 50 vans. For Sarah, her ApoB would be much lower, reflecting only 10 vans. Same cholesterol level. Completely different ApoB. Completely different cardiovascular risk. Who is most likely to have a high ApoB with normal cholesterol? This pattern, where ApoB is elevated but LDL cholesterol looks normal, is particularly common in certain groups. People with type 2 diabetes or prediabetes. Their LDL cholesterol is often normal or even low, but they have a very high number of small, dense LDL particles. Their ApoB is elevated. Their real risk is being completely missed. People with a large belly, what doctors call central obesity or visceral adiposity. Even if their weight seems acceptable overall, central fat drives exactly this pattern of many small dangerous particles with normal cholesterol. People with high triglycerides. When triglycerides are elevated, the standard calculation used to estimate LDL becomes inaccurate. It frequently underestimates the true LDL particle count. ApoB gives a far more reliable picture. People who are on statins with apparently well-controlled cholesterol, but who still have heart attacks. Their LDL has been reduced, but their particle count may still be elevated. ApoB reveals this hidden risk. If you fall into any of these groups, ask your doctor for an ApoB test. It is a simple blood test. It could completely change how your cardiovascular risk is managed. What the guidelines say. The latest European Society of Cardiology guidelines, updated in 2023, now recommend ApoB as a preferred treatment target in high-risk patients. This is a significant shift from previous guidance, which focused almost entirely on LDL cholesterol. The American Heart Association and American College of Cardiology also recognize ApoB as an important risk marker, particularly when there is uncertainty about whether to start or intensify cholesterol-lowering treatment. In simple terms, the world's top heart organizations are now saying that ApoB gives us a better picture of cardiovascular risk than LDL cholesterol alone. What is a safe ApoB level? For most people, below 80 mg/dL is considered acceptable. For people with diabetes or other risk factors, below 65 mg/dL. For people with established heart disease, below 55 mg/dL. For very high-risk patients, some guidelines now suggest below 45 mg/dL. If your doctor has never mentioned ApoB, ask for it at your next appointment. Tell them you want to know your particle count, not just your cholesterol level. What you should do right now. 3 simple action steps from today's video. Step 1. At your next blood test, ask specifically for ApoB to be included alongside your standard cholesterol panel. Step 2. If you have diabetes, high triglycerides, central obesity, or a history of heart disease, this is especially important for you. Do not wait. Ask at your next appointment. Step 3. Know your number. Write it down. Track it over time. ApoB below 65 mg/dL should be your target if you have any cardiovascular risk factors. Coming up in Part 2, we have covered ApoB today, why it matters, what it measures, and who needs it tested. But there is another hidden cardiovascular risk factor that affects 1 in 5 people, and it is even less well known than ApoB. It is called lipoprotein A, LPA, and it is the most common inherited cardiovascular risk factor in the world. It cannot be changed by diet. It cannot be changed by exercise. Standard statins barely touch it. And most people, and many doctors, have never heard of it. In Part 2, I will explain exactly what LPA is, what it does to your heart, who should be tested, and the brand new treatments that are about to change everything. Stay tuned for Part 2, coming very soon. If you do not want to miss it, subscribe right now and hit the notification bell. Part 2 could be the most important video I have made. This is MRCPdoc, internal medicine physician, and I'll see you in Part 2.